Proud to present Dr. David VanderWeele tonight. Dr. VanderWeele did his MD and PhD at University of Chicago, and then continued his work at the NCI. There he focused on genetics and the role of precision medicine, particularly for the benefit of prostate cancer patients. He's going to talk to us tonight about the Pi3 Kinase Akt Pathway and its inhibition for the treatment of metastatic CRPC. Thanks very much for being here, David. Please let me know when to advance the slides.
All right, thank you very much, Ashley. Yeah, if you could go ahead to the next slide. So I don't have any financial disclosures. I will discuss some clinical trial results for therapies that are not approved by the FDA. Probably more importantly is my bias interest in this pathway in this area for many years, and also on the PI for a trial involving an AKT inhibitor. Next slide. So the objectives for today are to review the PI3 kinase Akt pathway and its role in cancer more generally, and then discuss Pi3 Kinase Akt pathway alterations in prostate cancer specifically. We'll talk about mechanisms of disruption and activation of the pathway and implications of pathway alteration. And then we'll move on to discuss inhibitors of the pathway and recent clinical trial results, looking at efficacy data and response, and some discussion about biomarkers. So when the Stand Up to Cancer team first published an overview of the landscape of genomic alterations, this is back in 2015, they looked at 150 patients with metastatic CRPC. There are genes that are mutated going down along the side, and the patients go across the top right. There's 4 genes up at the top that are altered more frequently or relatively high frequency, and then a pretty long tail of other genes that are altered a lot less frequently. Next slide. Of course, one of the things that they were interested in was, are there biomarkers or actionable mutations that we should be looking at for prostate cancer? And in the orange bar, they're showing that almost all cases did have an informative aberration. Looking at the first yellow bar, 60% or so of patients had an alteration in the androgen receptor. So AR amplification or mutation, and of course that's been our major target for decades. But in the next bar, yellow bar, there were 60% or so of patients who had an additional actionable mutation that was not androgen receptor or AR pathway. Next slide. Of course, this has been realized with the approval of some biomarker-specific therapies. Starting in 2017, pembrolizumab received a tissue-agnostic approval for cancers for solid tumors with mismatch repair deficiency or microsatellite instability high. In metastatic CRPC, that's probably around 3% or so of cases. And then last year, we received approval, accelerated approval for rucaparib and olaparib. Rucaparib for patients with mutations in BRCA1 or BRCA2, which is probably about 10 to 15% of cases or so, and olaparib following immediately on its heels for those with BRCA1, BRCA2, ATM mutations, or 12 other genes, as shown, demonstrated efficacy in the PROfound trial. And so that brings us up to about 20 to 25% of patients or so. Next slide. But the topic for today is the PI3 kinase pathway, which really was the one pathway with the highest frequency of alteration in this initial landscape of genomic alterations for CRPC. And estimated, at least in this report, about half of patients with CRPC having alterations in this pathway. Next slide. So the PI3 kinase Akt pathway, many of you may be familiar with it. For those who aren't, it's a signaling pathway that's downstream of growth factor receptors and other receptors. AKT, shown by the blue circle there, is a central node in this pathway. Importantly, PI3 kinase, which is an oncoprotein, is a key upstream positive regulator of this pathway, converting PIP2 or stimulating the conversion of PIP2 to PIP3. And then P10, a tumor suppressor, is a key upstream negative regulator of the pathway, leading to the reverse process. It's a phosphatase leading to dephosphorylation of PIP3 back to PIP2. And so loss of P10 leads to downstream activation of AKT. And downstream of AKT, you can see that there are many important cellular functions that are regulated, including growth, survival, proliferation, and metabolism. Next slide. We often depict this as a somewhat more simplified linear pathway. In reality, these signaling pathways are probably part of a more complex network. Here again, AKT is shown as kind of a central node, but also if you were able to see the more gritty details, you'd see that there is crosstalk with the RAS-RAF-MAP kinase pathway, also downstream of growth factors. There's some interaction with the AR signaling, shown in the left on green, which we'll get to in more detail later. There's also feedback inhibition, so mTORC1, so mTOR being downstream of AKT, and mTORC1 and mTORC2 being two larger complexes, and getting feedback activation of the pathway if you have inhibition of those downstream targets. Next slide. So it's long been known that the signaling pathway is important in cancer. This figure comes from a review a couple years ago looking at frequency of alterations in a number of cancers. You see that prostate cancer sits about in the middle, and in this this review estimated alterations in the PI3 kinase pathway of about 40% or so. And here they're also depicting the type of alterations that lead to activation of the pathway. The dark blue for prostate cancer signifying it's most often with deep deletions. Next slide. And so how is PI3 kinase Akt pathway deregulated, or how do we get activation of this pathway? So for prostate cancer especially, most of the time this is through loss of negative regulation, and so loss of that brake on the pathway, the phosphatase P10. And as a prior figure implied, most of the time this is through deletion of the P10 gene. More recently, with more careful next generation sequencing techniques, we've seen that there's also translocations that can interrupt this gene, which can be difficult to pick up on a next generation sequencing. There can also be loss of function or dominant negative mutations, point mutations in the gene. Other possibilities are certainly possible with potentially methylation of the gene. Another, at least theoretical, negative regulator of the gene is the PIK3R1 gene, which is the regulatory part of the PI3 kinase protein. And you can get unregulated positive signal through gain of function of the other gene contributing to PI3 kinase, the PIK3CA gene, with oncogenic mutations, hotspot mutations. These are certainly well known in breast cancer, also described in ovarian and colorectal cancers, and to some extent also can be identified in prostate cancer, as well as hotspot mutations or potentially amplification of the AKT1 gene. In theory, you could also get activation of this pathway more indirectly through upstream activation of the receptor tyrosine kinases that lead to activation of, within the cell, of the PI3 kinase Akt pathway. Next slide. So what about the frequency of these alterations? Again, that Stand Up to Cancer report, the original one from 2015 is shown on the top right, where they estimated about half of cases had an alteration leading to activation of the PI3 kinase pathway. Older reports, such as the one from Memorial Sloan Kettering in 2010, estimated that nearly 100% of advanced metastatic prostate cancer had inappropriate activation of this pathway. That estimate is probably a little too high, or wasn't specific enough activation. They're looking at too broadly. In the updated Stand Up to Cancer report from 2019, incorporating both the East Coast and the West Coast DREAM teams, and looking specifically at the 4 genes that I've mentioned, PTEN, PIK3R1, PIK3CA, and AKT1, you see about 43% of cases, you can see genetic alteration, presumably leading to inappropriate activation of this pathway. And again, as depicted by all the dark blue next to the PTEN gene, you can see that most of the time that's through deep deletion of the negative regulator PTEN. Next slide. So activation of the Pi3 Kinase Akt pathway we think of as a potential biomarker for inhibitors of this pathway, but it also is prognostic. And so it's long been known for advanced prostate cancer that patients with PTEN loss have worse outcomes. So that includes worse prognosis. If you have loss of PTEN, you're more likely to have higher Gleason grade on prostatectomy, more likely to have worse clinical outcomes on active surveillance, more likely to have relapse after radiation therapy, biochemical recurrence after prostatectomy, or early prostate cancer mortality. In fact, one group has looked at immunohistochemistry for PTEN and found that it was basically as informative as the Polaris transcriptome-based prognostic assay, biomarker assay. So in addition to worse prognosis in general, PTEN loss also predicts poor response to AR-targeted therapy. So there's more rapid development of castration-resistant prostate cancer. There's a lack of response to neoadjuvant therapy with an AR pathway inhibitor, and earlier progression on AR-targeted therapy like abiraterone with prednisone. As an example, on the next slide, Mary Ellen Taplin's group has probably has the largest experience with neoadjuvant therapies with a variety of strategies to look at to be inhibiting androgen receptor and testosterone signaling. And so this was a combination of a number of these trials looking at outcomes for patients on the trial. And they found that patients receiving neoadjuvant abiraterone or enzalutamide, if they had an exceptional response with either PT0, so complete response on prostatectomy, or had minimal residual disease on prostatectomy, none of those patients had biochemical recurrence looking out 4 or 5 years or so. That's the upper black line, as opposed to those who did not achieve an exceptional response in the gray line, who half or more than half by the time you got out to 5 years had exceptional or had biochemical recurrence. Next slide. In efforts trying to predict which patients were likely to achieve an exceptional response, they looked at a number of different markers, including looking at PTEN. And so in the 23 patients who had loss of PTEN, 0 of them achieved minimal residual disease, and all 23 were non-responders, as opposed to those that had intact PTEN protein expression. 19% achieved minimal residual disease or had an excellent response, and 80% were non-responders. So not likely to respond to AR-targeted therapy in the neoadjuvant setting. Next slide. And one reason for that may be reciprocal crosstalk between AR signaling and PI3 kinase AKT signaling. So this was demonstrated probably most notably about 10 years ago or so by Brett Carver, just noting that there was sort of reciprocal activation when you try to inhibit one of these pathways or the other. And it's depicted here in this figure, showing that AKT, there tends to be feedback inhibition of receptor tyrosine kinases that may lead to phosphorylation and activation of androgen receptor. Conversely, androgen receptor leads to transcription of AR-targeted genes, among which are negative regulators of AKT, including PH-LPP and FKBP5. I think the exact mechanisms have been, some mechanisms have been demonstrated in vitro. It may not be limited to one specific mechanism, but certainly in preclinical settings, it's often seen that if you have activation of AKT, you have decreased signaling through AR, or certainly decreased reliance of signaling through AR. And in the clinical setting, you often see that if there's PTEN loss or other evidence of PI3 kinase AKT pathway activation, a lot of these patients have a lower PSA, have decreased AR activation based on transcriptome analysis, and have shorter duration of response to AR-targeted therapy. Next slide. So since there's been association of loss of PTEN or activation of the PI3 kinase AKT pathway with solid tumors in general for quite a while, there's also been development of a lot of inhibitors of this pathway, focusing on different nodes within the pathway. So there's pan class 1 isoform-specific PI3 kinase inhibitors. There are inhibitors that are dual inhibitors of PI3 kinase, as well as mTOR, which are both upstream and downstream of AKT. There's mTOR-specific inhibitors like everolimus or temsirolimus, which of course we know from renal cell carcinoma, and inhibitors of AKT itself. Next slide. Because of the association of this pathway with aggressive prostate cancers, a lot of these have been looked at in prostate cancer with a lot of negative trials and a lot of negative data. This is from an older review of a number of these inhibitors, which have since been abandoned for looking at for prostate cancer. Next slide. So in summary of the first part, the PI3 kinase AKT pathway is a key pathway regulating growth, proliferation, metabolism, and survival. It's deregulated in a high percentage of cancers. This includes prostate cancer, while it's deregulated in a higher number of some other cancers. Within prostate cancer itself, there aren't a lot of pathways that are hit frequently, and PI3 kinase AKT rises to the top of that list. Despite this, historically, targeting the pathway has been difficult. Though we often depict it as a linear pathway, it's probably better to think of these things as a network with crosstalk between pathways. This includes AR signaling in the PI3 kinase AKT pathways, as well as other pathways such as MAP kinase pathway. There's feedback activation. So if you try to block one node, you can sometimes get compensatory activation of another part of the network or of a pathway. In addition, there's some toxicity that limits the dosing that you can give for these inhibitors. Next slide. So that's sort of the historical knowledge of the pathway and interest of the pathway, with relatively disappointing results clinically. But now, more recently, there is renewed interest in this pathway, again, including for prostate cancer. And that's largely focused around these new AKT-specific inhibitors, ipatasertib and capivasertib. And so that's what we are going to focus on for the remainder of the talk, is looking at these AKT inhibitors and the clinical experience with them, which now have both entered into phase 3 studies. Next slide. So ipatasertib and capivasertib, as opposed to the allosteric inhibitors in the past, these are ATP competitive inhibitors, which may be one reason why they may be more effective than like MK2206, which has been looked at in the past. They're quite specific for AKT, but also are pan-AKT inhibitors, so inhibiting AKT1, 2, and 3. And updated from when this review was done in 2019, actually both of these drugs are now in phase 3 clinical trials. Next slide. So the trials we'll be talking about ipatasertib in combination with abiraterone in both phase 2 and phase 3 studies for metastatic CRPC, as well as capivasertib, which has been used in a phase 2 study with docetaxel, PROCADE study. We'll talk more about the first two. Next slide. So the A-Martin trial, this is a phase 2 study with the AKT inhibitor ipatasertib in combination with abiraterone. This is for late-stage metastatic CRPC patients who had previously received docetaxel and not received abiraterone. It has a radiographic progression-free survival endpoint. This was fresh off of the early phase 1 studies. And so they're looking at 2 different doses of ipatasertib, as well as abiraterone plus placebo arm. So a 3-arm study. On the right, you see Kaplan-Meier curves for radiographic progression-free survival, as well as for overall survival in the intention to treat population. And so there's some modest improvement there, but it does not reach statistical significance. This was not a biomarker selected trial, so it was open to patients regardless of PI3 Kinase Akt Pathway activation. But they did also collect tissue and perform analysis looking at biomarker. And they actually did that 4 different ways. They did that through immunohistochemistry with 2 different assays. One is an assay being developed by Genentech, who makes ipatasertib, Ventana IHC. Another one was through an assay developed by the Institute for Cancer Research, who ran the study. And then they also looked at FISH, so fluorescent in situ hybridization, looking for deletion of PTEN, as well as performing next generation sequencing to look at alterations in the PTEN gene. So next slide. If you break down the results, again, focusing on radiographic progression-free survival, and for patients, and for looking at a comparison between placebo and patients receiving what's now the recommended phase 2 dose, ipatasertib 400 milligrams, you see that there is significantly more benefit from adding ipatasertib in the PTEN loss population, shown on top, compared to the PTEN non-loss or intact, PTEN intact population. And this is determined by immunohistochemistry through the ICR assay. Next slide. So follow-up to that study was the iPotential 150 study, which is a phase 3 study looking at first-line metastatic CRPC, as opposed to more advanced CRPC with prior docetaxel. This study had co-primary endpoints of radiographic progression-free survival in the intention to treat population, as well as in the PTEN loss population. And again, this was not biomarker selected, but is biomarker stratified, I believe, using an immunohistochemistry assay from Ventana. In this one, they just settled on 2 arms, Abi plus placebo versus Abi plus abatacertib at 400 milligrams. Next slide. And so here's the schema again. Stratification was P10 loss by immunohistochemistry, as well as docetaxel, the means of progression, looking at liver lung metastases and geographic region for this global study involving over 1,000 patients. Patients were randomized 1-to-1 to receive placebo or abatacertib along with abiraterone. Next slide. Here's the demographics. So patients were generally around 70, about a little bit less than 20% had received prior docetaxel, and about 10 to 15% had visceral metastases in lung or liver. Next slide. So here's the data that was presented at ESMO by Johan de Bono. And so this is focusing in on the patients with loss of P10 by immunohistochemistry. And so this was a positive study with a p-value of 0.0335, though the hazard ratio is just 0.77, with improvement in radiographic progression-free survival in those patients with loss of P10 by immunohistochemistry. And then you can see the separation of the curves there. A 2-month improvement radiographic progression-free survival. Next slide. If you look instead at the overall population, intention to treat population, there was again a modest improvement in radiographic progression-free survival, the p-value of 0.0431, although this did not meet the co-primary endpoint. Next slide. And that's because the way they designed the stats, where they looking for an alpha 0.05 in the P10 loss population, where it's a p-value 0.01 in the intention to treat population. So they met one of the 2 co-primary endpoints. The overall survival data is still immature. Next slide. If you look at different subgroups in the P10 loss population, you see there's overlap with the overall hazard ratio in all the subgroups. There is a bit of a shift of less, hinting at less benefit in those who had prior taxane, a bit of a shift towards more benefit in those with liver or lung metastases, although those are relatively small subgroups and wide error bars in both of those subgroups. Next slide. So that's the efficacy data. Now thinking more about the biomarker selection. Next slide. So in both the phase 2 and the phase 3 studies, it looked like there was more benefit from the AKT inhibitor if there was a more stringent immunohistochemistry cutoff used. And so on the left, that's the phase 2 study. As I mentioned, there were 2 different immunohistochemistry assays that were used. The ICR assay was more stringent, looking at 90% of tumor cells being negative for P10 before they would call it P10 loss, whereas the Ventana assay, they only required 50% of tumor cells being negative in order for them to call it P10 loss. And again, you know, these are subgroup analyses, relatively small numbers, but the hazard ratios are do look better for the more stringent cutoff with the ICR-IHC assay. On the right-hand side, looking at the phase 3 iPotential study, they looked at hazard ratio at, based on a number of different cutoffs for immunohistochemistry. And you can see that there begins to be a shift to the left with more benefit with abatacertib at 50%, but even more at 60%. And then the biggest benefit, although pretty wide error bars at 100% of tumor cells staining negative for P10. Next slide. And as I mentioned, in the phase 2 study, they also looked with FISH And with next generation sequencing, and this actually is from the phase 3 study where they also looked at next generation sequencing, looking to see that for the concordance between next generation sequencing and immunohistochemistry. So if you look in the top graph, that bar graph, horizontal bar graph, the top line is looking at immunohistochemistry, those that have PTEN loss in orange and those that have PTEN intact in blue. And then the next line down is next generation sequencing, those with a mutation predicting loss of PTEN in orange, and those with intact PTEN predicting or no mutation identified in blue. You see, and those for whom the sequencing was not informative are in gray. So when the sequencing was orange, the vast majority of time the IHC was also orange. But the other thing that you see is there's a lot of gray within the next generation sequencing. So a lot of patients had failure of the sequencing, and so they weren't able to get an informative result. It's also shown on the bottom, kind of stratified by different immunohistochemistry cutoffs, from 0% of tumor cells having PTEN loss way on the left to 100% of tumor cells having PTEN loss way on the right, and then separated into every 10% or so. And so again, in these vertical bar graphs, you see that most of the ones on the right, they're blue, so they suggest that there's PTEN loss by next generation sequencing. And most of the ones on the left are yellow or orange, indicating that there is no alteration in PTEN identified by next generation sequencing. But you do also see a lot of gray in each of those bars where the sequencing failed, and so you didn't have an informative result. Next slide. And so this is going back to the phase 2 study. Again, similar idea where the immunohistochemistry assays are shown in the top 2 rows, and then FISH, and then next generation sequencing below. Although here they are excluding those for whom the next generation sequencing did not work. So if the next generation sequencing showed loss of PTEN, the vast majority of the time you saw that loss by immunohistochemistry as well. Although there were additional cases that were negative by IHC that you were not able to identify a mutation by sequencing. So by sequencing, about 30 to 40% of advanced prostate cancers have PTEN gene loss or mutation, but by IHC, in general, we're seeing about half of patients have loss of PTEN protein expression. Next slide. So looking back, if you look at the phase 3 study, for those cases that did have informative next generation sequencing, and instead of looking at patients' PTEN loss by immunohistochemistry, you look at those with PTEN loss by sequencing, you actually see an improved hazard ratio, so improved from 0.77 down to 0.65 and greater separation of those curves, as you can see. Next slide. So most of the focus in the prostate world is on PTEN, because we do see loss of PTEN as a pretty frequent event in advanced prostate cancer. But this comes from basically a case report and then additional preclinical data looking at alterations in AKT, including a hotspot activating mutation. So on the left are some xenograft models, one that has an AKT1 mutation, hotspot mutation, and then the one on the right with loss of PTEN, and they were treated either with control or with ipatasertib, the AKT inhibitor ipatasertib. And you can see with the one with the AKT1 mutation had a pretty significant response to ipatasertib. And that goes along with this case report on the right-hand side where the patient received prior docetaxel, enzalutamide, radium, and then received monotherapy with ipatasertib. and had a 50% decline in PSA that lasted about 6 months or so. So suggesting that it's really activation of the pathway and not just loss of PTEN that's important or that would predict benefit from this AKT inhibitor, which makes sense biologically. Next slide. And so the ipatasertib, the iPotential 150 team looked not just at loss of PTEN by next generation sequencing, but also included alteration of the pathway through hotspot mutation in AKT1 or in PI3K, the positive regulators of this pathway. And again, they see a hazard ratio of 0.63. So, the bulk of these patients had alterations in PTEN, but if anything, a slight improvement in that hazard ratio, suggesting that PI3K and AKT1 mutation are likely also worthwhile biomarkers to be thinking of in predicting response to this AKT inhibitor. Next slide. So that's the efficacy data, both by PTEN loss and then thinking a bit more about other ways to be thinking of these biomarkers. What about the safety and toxicity of ipatasertib? Next slide. So in the phase 1 studies, they looked at a range of ipatasertib dosing levels, of course, getting up to 800 milligrams daily dosing. 400 milligrams is the recommended phase 2 dose and what was used in phase 3, and relatively well tolerated with not a lot of AEs. Generally, things that they were looking at were diarrhea, nausea, hyperglycemia, and rash. These are all things that we already associate with mTOR inhibitors like everolimus or temsirolimus, which makes sense since it's we think of it as downstream of AKT in this pathway. Next slide. Toxicities were seen when combining ipatasertib with abiraterone. Again, the toxicities that they're kind of looking out for and expecting, especially seeing rash, as well as diarrhea and some hyperglycemia, as well as some liver enzyme elevation, some you see the transaminases being elevated there. Significantly increased in the ipatasertib plus abiraterone arm as opposed to the placebo plus abi arm. So when combining these agents, we know that AR pathway inhibition, ADT, can affect glucose control. When you're adding in the prednisone with abi, that can affect glucose control even more so when you're adding in the AKT inhibitor. And you can also get rash, diarrhea, and need to be monitoring LFTs for these folks. Next slide. And so those were the AEs that were seen in terms of the AEs leading to discontinuation. It was about 20% that discontinued placebo or ipatasertib in the phase 3 study, as opposed to only 5% of those in the placebo arm. Next slide. So that's all about ipatasertib, which they focused their efforts on combining with abiraterone, thinking about the interaction in the crosstalk between the Pi3 Kinase AKT pathway and AR signaling. The other big new AKT inhibitor on the block is capivasertib, and here we have the PROCADE study that was recently published in JCO, which was looking at docetaxel and capivasertib in a phase 2 study. Again, it was patients with mCRPC. There was no limit on prior AR pathway inhibitors, but they could not have had prior docetaxel for CRPC. I think it was modified partway through to allow prior docetaxel in the hormone-sensitive setting. This study was not biomarker selected, although they did do some biomarker analysis, which was a combination of immunohistochemistry and next-generation sequencing. Patients were randomized to receive docetaxel up to 10 cycles plus placebo or plus capivasertib at 320 milligrams BID. Now this dosing is on a different schedule with 4 days on and 3 days off on every 7 days. Next slide. Interestingly, this study was a negative study. It did not meet its primary endpoint of progression-free survival. You see very modest improvement, progression-free survival in the Kaplan-Meier curve on the left, with largely overlap between those curves. Although there was a separation of curves in overall survival, and this was a secondary endpoint with a hazard ratio of 0.54, which with confidence intervals that did not cross 1. Next slide. Going back and looking at biomarker and interaction with efficacy, it turns out the efficacy was independent of the biomarker. So both for progression-free survival and for overall survival, there was not an improvement. Well, first of all, not much difference between the hazard ratios. Those are biomarker positive or negative, and no improvement in response in those hazard ratios. Next slide. So other clinical trials that are out there in prostate cancer, I'm thinking about hepatosertib. It is also being looked at in combination with rucaparib, the PARP inhibitor rucaparib. This study is open to prostate cancer, breast, and ovarian cancer. And that's actually based on data on the Pi3 Kinase Akt Pathway playing a role in DNA damage repair. In addition, there's a known role for Pi3 Kinase Akt Pathway in immunotherapy or in resistance to immunotherapy. And so hepatosertib is being looked at in combination with atezolizumab in CRPC as a way to enhance immune response. Hepatosertib, I think actually the arm is closed now, but there was an AKT1 mutation, hotspot mutation arm within the MATCH trial, the NCI MATCH trial, that looked at hepatosertib. The Vancouver prostate cancer group, the British Columbia prostate cancer group, their umbrella trial, prostate cancer biomarker enrichment and target selection, or PCBETS, they do have an hepatosertib arm there, which I believe is at least AKT1 hotspot mutation. That is the group that had that kind of case report, and along with the preclinical data to go along with it. In addition, there is a neoadjuvant hepatosertib plus darolutamide study in biomarker selected patients, which we hope to have open here soon, and is my main conflict of interest, because leading the effort to try to get that open. Capivasertib is been looked at in phase 1 studies in combination with abiraterone and with enzalutamide. That data is not yet published, but the Capitello 281 phase 3 study combining capivasertib and abiraterone in metastatic hormone-sensitive prostate cancer is open and recruiting. So presumably they have data showing safety at least, and maybe even some efficacy from that phase 1 study. We'll be looking for that data. And again, capivasertib has also been included in the MATCH trial. Next slide. So this is just the schema for the Capitello 281 study. Again, this is metastatic hormone-sensitive prostate cancer. This one is biomarker selected, selecting for loss of PTEN by immunohistochemistry, which is determined by central review, although I do not know the details of that, what kind of cutoff that they are using. And patients are randomized 1-to-1 to receive either capivasertib or placebo, in addition to abiraterone. I've written here days 1 through 4 of a 28-day cycle, and actually I don't think that that's correct. I think it's every 7 days, but it is a higher dose of capivasertib than what was used in Procade. And here the primary endpoint is radiographic progression-free survival with a number of important secondary endpoints. So this study is open and recruiting now. Next slide. So summarizing the clinical data, there's efficacy of ipatasertib and abiraterone. It's been demonstrated both in phase 2 and phase 3 studies, especially for patients with loss of PTEN. The efficacy in phase 2 looked pretty significant. The efficacy in phase 3 met the primary endpoint, although not as impressive, and more benefit is seen with more stringent cutoffs in post hoc analysis, and looking at by immunohistochemistry, or also more benefit seen in patients that are biomarker positive by next generation sequencing, focusing especially on PTEN, PI3K, and AKT1. So I think at this point we would say that optimal biomarkers are still unknown, but immunohistochemistry, well, yeah, still unknown, and I think still an area of interest. Capivasertib added to docetaxel did show an overall survival benefit, although this was a secondary endpoint and it did not meet the primary endpoint for radiographic progression-free survival, so this still needs to be confirmed. There are toxicities with these drugs. They're similar to mTOR inhibitors, so they're things that many of us are familiar with, including rash, hyperglycemia, and then some GI toxicities, especially diarrhea, and then transaminitis. They seem like they're things that will be manageable either through eligibility criteria or through supportive care or adjustments with those. Most of what we focused on is looking at prostate cancer and thinking about inhibition of Pi3 Kinase Akt in patients that have deregulated activation of this pathway, but additional trials are exploring roles for AKT inhibitors in immune response and in roles for DNA repair, so far looking especially at combination with PARP inhibitors. And so that is it. Next slide. Happy to take any questions, and thank you very much for your attention.
Thank you. That was excellent. Let me just figure out my screens here, and I have a question. That was excellent. I have a couple questions for you. One is, and I know it's you said it's your conflict, but I want you to talk a little bit about the neoadjuvant trial. A couple questions, in terms of looking at response and setting, because PTEN is lost so early in prostate cancer, and I used to think of the pathway for the PI3 kinase as being one more of like driving invasion and growth more than metastasis. Is there any thoughts about, moving it earlier in disease space? I mean, I know your neoadjuvant trial is mostly a pharmacodynamic trial potentially, or maybe looking at potential for priming, but like, because it's a mono agent, it's has less toxicity than when combined with something that also causes liver toxicity. Is there any thought of moving it up earlier? That it's something that's more important in invasion or microenvironment. And what are your thoughts on that? Like, what do you hope to gain if your neoadjuvant trial does open and go forward? What would be the next steps?
Yeah, so just to describe the neoadjuvant trial a little bit more, it actually is a phase 1/2 study because it's being combined with darolutamide as the AR pathway inhibitor of choice. Darolutamide plays better with others with fewer drug-drug interactions than, say, enzalutamide or apalutamide. It also does not require the steroids that you need with abiraterone. There's generally not a lot of stress on the liver, but it's a new combination. So it starts off actually in CRPC, the phase 1 component, just combining ipatasertib and darolutamide, making sure that it does look like they're safe, like they are safe together. and then moves into neoadjuvant setting for patients with high risk localized or locally advanced disease planning on undergoing prostatectomy. And that portion is biomarker selected. So that endpoint is actually looking at pathologic response. So looking for complete response or minimal residual disease, largely based on that data from Mary Ellen Taplin's group showing that if you have minimal residual disease as defined by 5 millimeters linearly in the prostatectomy specimen, 5 millimeters of tumor, that none of those patients had biochemical recurrence. So, that's not a clinical endpoint that you can hang your hat on, but certainly is encouraging. So that really is that is what the endpoint is for the phase 2 portion. I think that this is a way to try to improve outcomes in patients that have particularly aggressive disease. I do think that those with PTEN loss, we know that's poor prognosis, higher likelihood of biochemical recurrence. They don't seem to benefit from other neoadjuvant therapy strategies targeting just AR. And so I'm hoping that this ends up being a way to try to improve the chance of cure with surgery and reduce the biochemical recurrence. Of course, that's something that we're looking at as well, but with relatively small numbers in the study. So where do we go from here? You talked about less toxicity as monotherapy, but I guess because there is enough of a network in these signaling pathways, I don't think that monotherapy is going to be the way forward. In the end, I think we're going to need sort of hitting these pathways with multiple different drugs. And so trying to find the right combination and the right drug combination, the right biomarker in order to select the patients. And then I don't know if there's still more to be done with thinking about dosing or supportive care to reduce the toxicities or to make sure that it's manageable in patients and not too big a deal. So I think combination therapy is what we're going to be looking at, but other things that we consider doing is hitting it with one drug first and kind of expecting that we'd see upregulation of the other pathway and sort of coming in later with adding on the additional drug, sort of increasing sensitivity to the second drug that way. At least for right now, we're starting them both at the same time with a slight lead in the initial phase 1 CRPC setting. That might be another strategy in terms of thinking about timing and how to manipulate these pathways. But in the end, I do think we're going to need combination therapy, especially because at least right now, the biomarkers we're looking at are selecting patients with worse prognosis in general.
One more brief follow-up is, I know that when I was doing my PhD, like phosphoantibodies were notoriously very difficult to get clean signals. Ideally, if you wanted to know if the pathway was active, you'd be looking at phospho-AKT levels or you'd be looking at, TRC phosphorylation. Has the field changed a little bit? Have they thought about looking at these end-stream effectors or like actual byproducts of pathway activation instead of looking for activating mutations or loss of tumor suppressors?
Yeah, that's a very good question. I guess I would say that the answer is no. There are some other, like phospho-PRAS40 is another downstream protein marker that seems to be a little bit better when trying to look to see if you're actually hitting the target instead of phospho-AKT itself. But these are kind of transient effects, and so it's not really clear how helpful that is in the clinical setting. It certainly is a good biomarker if you're sacrificing mice in the lab and looking to see what's going on. The initial TCGA data buried in the supplement, they did RPPA assays, And they looked at loss of PTEN and then looked for activation of the PI3 Kinase Akt pathway by protein evaluation, and actually didn't really see much correlation there. I don't know that others are, I mean, obviously looking at sort of expanding beyond P10 and looking at PI3CA and AKT1, that's pretty low hanging fruit and kind of obvious. I don't think that there's been as much in terms of looking at downstream effectors, since, you know, that initial Taylor paper from Memorial Sloan Kettering in 2011 suggested, you know, close to 100% of patients have activation of this pathway in one way or another, which I think is probably true, but what's really, you know, which patients are really addicted to this pathway? That's really what you want to know, and that may be a little bit harder to suss out with the downstream effectors.
Let me see if there's any other questions, but I'll tell you a couple things. One is, and thank you very much. That was a phenomenal talk. And I also will tell you that I and a lot of the other surgeons at Northwestern are very excited about this trial. I think actually, if once it gets open, we'd have lots of patients if safety is established to put on it. I think it's you know, there's lots of good data that you presented for potential efficacy for those patients. Any other questions? And if not, I'll just announce that we're going to twice monthly with these meetings. Our next one will be on April 1st. Dr. Abdul Qadir will talk about MYC inhibition. So I hope to see everyone there. Any other questions for Dr. VanderWeele? One coming through the chat.
I see a question actually here from Alexander. Has there been any analyses into patients with co-occurring AKT1 mutations and PTEN loss? Actually, so there are some patients with co-occurring PI3CA and PTEN loss. AKT1, and if I'm not mistaken, AKT1 mutations and PTEN loss are kind of trend towards mutually exclusive, and so they seem to be kind of redundant, and they don't actually happen very often. But regardless, you know, it would kind of reinforce the likely addiction of this pathway for the tumor. And since the main way we have of inhibiting these right now is AKT inhibitors, thinking about biomarker setting, I think that would just be, you know, kind of reinforcing a good patient to select for use of an AKT inhibitor. I don't think there are enough of those patients out there to be thinking about sort of prognosis, looking at it that way, since AKT1 mutations are in and of themselves are not very common in advanced prostate cancer.
Remind us too, is ipitassertib, or however you pronounce it, right now it is not FDA approved for any indication, right? Or is it approved?
No, it is not approved for any indication. Most of the interest has been in prostate cancer with both phase 2 and phase 3 studies, as we talked about, and in breast cancer, where it's been combined with docetaxel and actually, or with the taxane at least, I think with paclitaxel. And also with atezolizumab, really looking at that, you know, immunotherapy adjunctive agent, thinking about it that way. And actually, they have some pretty nice data, but pretty small numbers of patients of eliciting immune responses in patients, kind of regardless of PD-L1 expression or other markers that would predict response to immune therapy. So there's definitely interest there in breast cancer. I think they're looking to spread out to additional tumors, thinking both about AKT, PI3 Kinase Akt pathway signaling, and immunotherapy, and DNA damage repair, you know, with PARP inhibitors, with radiation, thinking about those combinations. But most of the data right now has been in prostate and breast cancer.
Great. Thank you again, and thank you everyone for attending. Again, our next meeting is going to be on April 1st. don't forget that you can claim a CME credit for these meetings now, and it should be in the chat box, the code for claiming CME. Thanks again, Dr. VanderWeele. That was really phenomenal.
Sure, no problem. Thank you.